Hello and welcome everyone to this sponsored session to a very important topic named Advancing Valve Repair, Mastering Diverse Mitral and Tricuspid Regurgitation Anatomies with the PASCAL Precision system. My name is Philipp Lürz. I will lead you through the session together with Wolfgang Rottbauer. We have a fantastic panel and a group of discussants: Carmelo Grasso, Jörg Hausleiter, Harald Lapp, Tiffany Patterson, Marta Sitges, and Stefan von Wadeleben. The objective of that session is for us to learn about the latest clinical and real-world evidence, both for mitral and tricuspid TEER using the PASCAL system, to discuss, interact, and really have a sophisticated interaction about different cases, how they could be approached, and how the PASCAL Precision system is best used in these. We will also see recorded cases to enrich our learning. I would like to ask you to take on and make sure that the audience will be involved.
Yeah, I give my very best. Hello to everybody. And we try to be as interactive as possible because it's already pretty late and we just had this little celebration, 20 years of TEER. And we make it now more complicated because nobody was talking about the tricuspid valve in that last session. We missed that, I think. This is the future we have to go. And you will learn today that we will address both valves, and we get started on the mitral valve, and then we move over to the tricuspid side. I think this is how we set it up, Philip. Yeah, that's correct. And I think you are starting on a very important trial, and that is focusing on degenerative mitral disease. And it's the Class 2D trial, and then you will show us, I think, the one-year data. And with that, then Ralph will show us the registry data, and then we go into a discussion on the mitral side and see what PASCAL is achieving for these patients.
Fantastic. Good. So it's no secret that there are two different devices when thinking about TEER for the mitral valve. So obviously, any decision should be based on proper evidence and a very good study. We do have a head-to-head comparison, the randomized trial, the Class 2D trial, looking at patients with degenerative disease, and I will guide you through the latest results of that randomized trial. So the device we're discussing is the PASCAL transcatheter valve repair system. It comes in two different devices, the PASCAL ACE and the sort of normal PASCAL device. And this device was compared really in a head-to-head comparison to the MitraClip in a prospective multi-center, multinational randomized controlled pivotal trial, the CLASP 2D trial. It had everything what you would expect from a properly designed trial: central screening committee, echocardiographic core lab, clinical event committee, data safety monitoring board. Patients were enrolled when they were symptomatic and had at least 3+ or greater mitral regurgitation. And what's important, degenerative mitral regurgitation, that was subject of the investigation in that trial. The idea was that patients considered to be randomized should be suitable both for the MitraClip but also for the PASCAL device. The patients were then randomized in a 2-to-1 fashion. The primary endpoint was the analysis of non-inferiority with respect to effectiveness at 6 months, but we will also look today at the one-year data and see how well these two devices perform, especially when they are compared in a head-to-head fashion. Here you can see the centers who participated and enrolled patients in Germany, Switzerland, Canada, and the US. Overall, 300 patients were included and then, as said, randomized in a 2-to-1 fashion. And then for various reasons of study exits, we were left at the one-year follow-up with 177 patients in the PASCAL group and 88 patients in the MitraClip group. The baseline characteristics show that the two groups were actually well balanced. It was certainly a cohort of patients at advanced age. Mean age was more than 80 years. There was a small male predominance. We can say that these patients were clearly symptomatic, with the vast majority in NYHA class 3 or 4. They had increased risk scores. Left ventricular ejection fraction was normal, as maybe to be expected in patients with degenerative disease. The implantation success rate was really high in both treatment groups, 99%, no difference. Procedure time and device time was slightly longer for the PASCAL group, but then the number of mean devices was lower for PASCAL. You can also see the distribution of the different devices used, both for the mitral group, for the PASCAL group, but also for the CLIP group. What should be mentioned is the fact that in the PASCAL group, 21% of patients were treated with the latest iteration or generation of the device, the PASCAL Precision system, whereas in the CLIP group, almost 70% of patients were treated with the latest generation of the CLIP system, which is the G4. Safety, and this is quite encouraging, was comparable and was really good for both treatment groups with a low complication rate and a low cardiovascular mortality rate early on. But then also during follow-up, looking at the Kaplan-Meier curves at 1 year, almost superimposed the two lines, absolutely no difference. And here is the more detailed analysis of hard clinical endpoints, including all-cause mortality, cardiovascular mortality, freedom from heart failure hospitalization, and the combination. And again, these Kaplan-Meier curves, they are pretty much superimposed, no differences between the two treatment groups. Now we do the procedure to reduce MR, and here you can see how successful that was. Obviously, initially, a significant reduction in mitral regurgitation, and this initial reduction was well maintained during follow-up up to 1 year in both treatment groups. We look at a rate of 77% of patients ending up with mild or less MR in the PASCAL group, and 71% of patients ending up with mild or less MR in the mitral clip group. Obviously, the PASCAL group met the non-inferiority endpoint as pre-specified. There was some increase in gradient as to be expected for a TEER procedure, but again, there were no differences, and also the gradient, also during follow-up, was on average clearly below 5 millimeter of mercury, and the reduction in MR was associated with smaller left ventricular, both end diastolic and systolic volumes. And obviously this is important, there were also implications for patients' clinical status with improved symptoms, with improved NYHA class. So the clinical consequences of the procedures were thoroughly assessed, also according to quality of life and KCCQ score, as demonstrated here. Initial improvement, well preserved during follow-up with no further changes. So this is the first head-to-head comparison of the PASCAL system compared to the mitral clip. The PASCAL treatment group easily met the non-inferiority endpoint. We see in both treatment groups low complications rate, good freedom from MACE events also during follow-up, and we look at a high percentage of patients ending up with mild or less MR also at the 1 year endpoint. I've said at the beginning, or I showed it quickly, that there was one randomized arm, but there's also a registry, and that will be now presented by Stefan van Badeleben.
Thank you, Philip.
Maybe just to interrupt for a second, Jörg, what's the key finding of the randomized trial in your eyes? What fascinated you the most when you looked at the data?
Well, it's fascinating that we do have two devices that are equally safe, which I think is one of the most important aspects in all of our procedures. And it's very reassuring that they can really reduce the MR in this degenerative cohort very effectively, very durable, to a very similar extent, up to 1 year. This is at least what we see today.
So Ralph, let's see what the registry tells us.
Yeah, so I'm now presenting the small sister of the randomized cohort of 300 patients, and I'm moving down to a little bit more than 96 patients, and this is the yellow arm here on the right-hand side. Those patients that deemed eligible for randomization, and again, we had the same trial oversight that Philip was already mentioning. Again, the enrolling sites, 35 centers here across Canada, the United States and Europe. 98 patients being enrolled, 96 at 30 days, 87 at 6 months, and we report the 1 year results of 84 patients That means that we have a completed visit of 91.7% of those patients that had a complex and non-IFU situation in degenerative mitral valve disease. And the reasons for that are depicted on the left-hand side. You can see that there were multiple jets in this group. There was a bileaflet multi-scallop prolapse involvement. The orifice area was, with these prolapses, smaller than anticipated for normal patients, a larger flail width, and significant jets also in the commissural area. You can see it's about the same age distribution. Again, we're at the age group with the mean of 81 years. We have a male predominance of 60%, but I want to highlight in light blue that we have a large atrial fibrillation group with almost 70%, which is 10% higher than what we see in normal mitral cohorts. We have renal insufficiency in 40% of the patients, pulmonary hypertension in almost 60% of the patients, and we have a significant effective orifice area of 0.47. You can also see the distribution of the latest devices, PASCAL ACE, being used in 33.7%, and a combination of the older P10 system and the PASCAL ACE in about 11% of the patients. And 15.3% of all patients in this single-arm registry actually met 2 complexity criteria. If we look at the results and the composite MAE rate as well as cardiovascular mortality in this elderly population above 81 years, we can see that cardiovascular mortality at 30 days is 1% only, and at 1 year, which is actually spectacular, is 5.4% only. There's a very low rate of stroke given this elderly and very complex patient group. We can see that there is an underanticipated number of myocardial infarction with only 1 patient, new need for renal replacement therapy in only 1 patient, severe bleeding being well below 10% in the TEER group, and also only 1 patient equaling 1% with non-elective mitral valve reintervention. So if we look on the right-hand side in the freedom from MAEs, we see that 84% of the patients actually stayed away from major adverse events in this complex scenario group. And again, a more detailed analysis in all-cause mortality, and you can see that all-cause mortality is around 10%. Cardiovascular mortality has already shown slightly above 5%. Freedom from heart failure hospitalization in this primary MR group is also very high at 91.5%. And also the combined endpoint is pretty similar to the randomized group. So actually this group could have been added to the randomized group in a retrospective review of these patients being at 84%. And we can also see that the results in this more difficult group or more complex groups are also maintained. The MR1 rate is slightly lower. We saw ranges in the 70s with the randomized cohort. We see 62% here. But what is also important for these elderly patients that are above in the octogenarian area is 93% in complex situations, almost as high as in the randomized group, being MR2 plus or less in the single arm trial arm. We can also see that, of course, the gradients elevate, and they elevate slightly earlier and a little bit more as there were more small valves involved with less than 4 centimeters square. We can see the remodeling taking place first at the end diastolic volume, a little bit later at the end systolic, and this typically gives a short dip into the ejection fraction while maintaining stroke volume in these patients. You can see a very nice inversion of patients, 70% being in class 3 and 4, and moving in 80% down to class 1 and 2 in the New York Heart Functional class. And again, like in the randomized group, which was KCCQ, quality of life improvement of slightly above 15 points, we see 14.8, which is almost the same for these more complex patients. So the benefit, clinical benefit for these patients is equal to the randomized cohort. So also my summary slide here, these were patients that were elderly, octogenarians with complex mitral valve anatomy that were historically considered less suitable for TEER. The PASCAL system that was exclusively used in the single-arm showed a good performance in prohibitive surgical risk patients. We saw elevated STS and Euroscore 2. Outcomes at 1 year in this elderly population shows excellent safety, low mortality at 1 month and 1 year. We have seen significant and sustained MR reduction, 93 being below or equal to 2+, stable gradients staying in mean below 5, and see meaningful improvements in symptoms and quality of life. So the results from this registry confirm the clinical outcomes in the randomized cohort, also in this more complex single-arm cohort. Thank you very much for your kind attention.
Just a quick reminder to the auditorium, we are happy to address your questions. You can put them into the Slido, and then we will bring them up to the discussion.
Stefan, fantastic. Sometimes when we think about morphological suitability for TEER, we think into green, yellow, and red sort of patients. What color would you give to that cohort of patients?
Well, this cohort of patients is definitely in the border zone between yellow and red. And we're moving more and more to the red, so the red traffic light gets shorter and shorter. So we're getting more a green line in traffic. So unlike London, we're moving ahead, I think, in M-TEER.
Marta, do you think that data supports treating these yellow patients?
Well, it helps, but we have to keep in mind also that surgical results in the generative MR are very good. So I think this is very good evidence in patients with high surgical risk, which up to now had no other option, maybe. So with the GAIN experience and with the more technological development of devices, you are able to treat these high-risk surgical patients.
Absolutely. And I think it's fair to say that that's a slightly different cohort to what we normally see in surgical experience, given the fact that the mean age was older than 80 and certainly increased risk.
Yeah. So maybe, Harald, addressing you, the results are really impressive. And I think, do we need a randomized trial going against surgery in low-risk patients because we get so good results? What are your thoughts on that? Is that an important trial we should aim at, or should we leave it there?
First of all, I'm very happy that we see some kind like a class effect of treatment. So the TEER treatment, whatever device we use, is a safe and very effective procedure. And I think a randomized trial compared to surgery, I think we will not be helpful because we are treating completely different patients. The surgical patients, they are, as Philip told us, they are somewhat younger and not so high, such a high comorbidity. And currently, I'm not sure if we really should go to these low-risk patients.
Okay.
Tiffany, a quick word towards the treatment goal. We've seen the percentage of patients with who are left with MR1 or less and those with moderate or less. What's the treatment goal in DMR for you?
Well, we always got to aim to completely reduce the mitral regurgitation whenever we can. Maybe that's not so feasible sometimes in these complex red cases, but we've got to try harder and maybe perhaps accept a slightly longer procedure to try and eradicate as much of the mitral regurgitation as possible. That's what the data shows us. Fantastic.
Although, okay.
I think we should move on.
Yeah, after all the evidence, let's become a little bit more practical.
Yeah, exactly. So I think now we will look into real two cases, and we go back to degenerative disease, but also to functional MR. We're looking forward, Camara, to the presentation, and Marta will give us then the image analysis.
Yes, thank you for the presentation. And before to go deep into the case, I will just show very briefly the new precision system that, as you know, many of you maybe already used the new system, and it has become really accurate and intuitive, and it's even smoother than the previous version. It's more stable and more easy to use. You already seen that we have, as you know, two configurations of the PASCAL with the ACE and the P10. And I will show just briefly some data of retrospective analysis conducted by Edwards. And these data are collected by the specialists that are in the cath lab during the procedure on over 3,000 patients. As you may see that the majority of patients has FMR and DMR, it's almost equally treated, and only 20% on mixed etiology, and the acute efficacy is very high. since 84% had an acute efficacy with a reduction of mitral regurgitation to non-trace to mild mitral regurgitation. Procedural success, 100%, with very low event rate and a very fast procedure. The mean average is 53 minutes without any worsening of the mean gradient. So let's go with the implant. It is preferred the PASCAL P10 when we deal with the FAMAR patient where we have restricted and shorter leaflet. We will prefer to use PASCAL ACE in commissural J, degenerative mitral regurgitation patient with longer leaflet than SCORDIR. And then I will show 2 cases about P10 and ACE. Still need consensus on more red zone, as we have seen patients that we have to find how to treat it. So first case is a female with a previous history of breast cancer and Hodgkin lymphoma, both treated with chemo and radiotherapy. She started to have dyspnea since 2015, and she was kept on follow-up by her own cardiologist. And on 2023, just a few weeks ago, I treated this patient because of mild effort dyspnea. And she was already on medical therapy. After our team decision, we decided to treat it with PASCAL implant. I will just show the mitral regurgitation and both bicommissural view and LVOT view, and just give you general impression with the 3D image, and then I will let Marta that will do the analysis of these images.
Thank you, Carmelo. So as you saw, this is a patient with a very enlarged atria. So you can see also here in this slide, so where you can see the intercommissural, where you have the lateral and the medial aspect of the mitral valve. So we have a large left atrium in a patient with preserved ejection fraction of the left ventricle, as you've seen in the movies. And what you can see here is in this lateral medial aspect, remember this is the appendage, so this means lateral, okay? It's very central, a very central jet. And if we cut an orthogonal plane across this intercommissural view, we can have here the anterior aspect and the posterior aspect. You see the aorta here, so this is the anterior leaflet, posterior leaflet. Again, very central jet, long leaflets here. Let's see. So let's go to a more detailed image of the mitral leaflets, if we can. Okay, so important, as you could, that's difficult to show in a still image, but there was no leaflet, no restriction in the motion of the leaflet, so it seemed that the underlying mechanism is more dilated annulus, and particularly a little bit of thickening here. The length of the posterior leaflet is adequate, 13 millimeters, maybe slightly thickened. There was also the previous story of radiotherapy. I don't know if they irradiated also the patient. And even here we can see a very small something which might seem a small chorda, sorry. Some issues here. Okay.
Marta, maybe in between,
No,
how would you call that? Is this mixed, functional, degenerative, functional ventricular, functional atrial?
I think it's a functional, atrial, secondary mitral regurgitation, atrial secondary mitral regurgitation, but as we have some lesions with this slightly thickening of the leaflet, we also have, as I'll show you here in the 3D, I'll show you here, there is a small chordal rupture, very small. So I think it's mainly atrial secondary MR, but with some mixed features, okay? So as you can see, this is the valve in systole, so this is closed. So we can see here what would be the regurgitant hole, and in the middle we have this small chorda, okay? This is the opening area, so it was a normal opening area, and the gap, the maximum gap here, so if we measure here, it's a central gap, and it's 4 millimeters. So I think I could conclude it's an atrial secondary MR with some mixed features of a little bit thickening, not much, okay? No restriction of the posterior leaflet, affordable gap, I think, 4 millimeters, central, and this is what I have to discuss.
Thank you, Marta. What do
So
you
what
think
are you
of the
going to
case?
do?
Do I proceed, or do you want to do a panel consensus, or do I proceed with the...
What are your thoughts?
Ralph,
Jörg.
go ahead.
I think there are changes to the leaflets, definitely. So for me, it would be somehow a mixed disease. There's also radiation involved. So I think these are not normal leaflets. So for me, it would be a combination, as Marta put it out already, of a dilatation, but also some restriction of the leaflets, and a mixed disease for me.
Okay.
And for sure, it's a high-risk patient. She's above 80 years old.
83. Yeah.
83 years old, so it's going to be probably a perfect candidate for an edge-to-edge repair.
Quick word about the strategy, Jörg?
I would probably go, of course, in the center of the valve, but I probably would use a precision ACE system. But I can also understand in this kind of pathology that standard PASCAL might also do the same great job.
Okay, let's see.
So let's go. I choose to implant PASCAL P10, so with the spacer in the center. And as you can see, we do the clasp check. We were well aligned, and the important thing in the TEER is to be perpendicular to the valve, and we perform the clocking to be perpendicular to the commissure line.
We don't see it
No
yet.
slides.
Can we have the slides up, please?
You have no slides?
Slides.
Thank you.
Okay. So we see the clasp check on the left, and the clocking of the system to be perpendicular to the commissure line. And then we went down into the ventricle, and you nicely see the leaflets that are laying on both the arms, and then the implant on the right, the implant closure, with this final result. We can see this PASCAL P10 implant in A2P2 position with MRI mild final result with a 3 millimeter mercury gradient, residual gradient. And this is the X-plane view with this mild regurgitation, residual regurgitation.
No doubt. Fantastic result. Quick word, why did you choose the device you've chosen?
With the P10, because in the function I prefer to use this. With the spacer, it is useful to fill the gap that you, Marta, have shown to us. And even because I don't want to put too much tension into the leaflet. And it is larger, and so my intention was to treat the patient just with one device. So the device larger is better for me, in my opinion.
So Tiffany, would you have used, you always want to have a perfect result, you told us. Would you have done some adaptation and regrasp one of the leaflets independently again to get zero regurg?
I mean, this is beautiful, isn't it? It's a lovely result. You've got a diseased valve. The leaflets aren't normal. And you had significant atrial functional MR. I wouldn't do anything differently here. This is lovely.
Okay, great. So I think we
Thank
move
you.
ahead.
So go for the second case. The second case was a male, 79 years old, with a severe degenerative MR. He has a previous stroke and Parkinson's disease, and started to have dyspnea in October 2023. We performed an angioplasty with a DES on obtuse marginal, and then we go to treat because of the comorbidity, to treat the valve percutaneously. And these are the images. You can see there is a flail of A2 leaflets with a severe eccentric jet. And even a 3D image nicely show the flail and the regurgitation. And Marta will go deeply into the image analysis.
Okay, so this is the long axis or the LVOT view. So here we have the aorta. So this is anterior again, posterior. So we have here clearly a nice prolapse of the anterior leaflet because the tip of the leaflet is overriding the plane of coaptation of the annulus plane. And this is exactly where the jet comes from. So due to this anterior leaflet prolapse, so if we go again to the biplane view, we have here again the intercommissural view. This is the LAO, the left atrial appendage. So we have medial and here lateral, medial and lateral. So we have here P1, A2 in the middle, P3 here. Okay, so we see that the A2 segment overrides a little bit, and if we cross here and we have the orthogonal plane, this is exactly where the prolapse is. So we have located the prolapse in P2, in A2, sorry. We also see it again with the color in the intercommissural view, and you can see that the jet is a little bit directly lateral because that has to make us think that the prolapse is not occupying the whole width of the A2 prolapse, and this is of the A2 segment, sorry. And this is exactly what we see in the nice 3D that Carmelo showed us. So we have here, again, for those who are less familiar with this is the aorta, this is posterior, this is medial, and this is lateral, okay? So we have here, again, we have A3, A2, and, P3. We have here A2, we have here A1, and we have here P2 and P1. So this is the prolapse area with this width, okay, that was around 8 millimeters, but we still have anterior leaflet here. What do I mean with this? That you have to go probably central, but a little bit medial. What else we have here? Finally, what we have here is the height of the prolapse. So how much the anterior leaflet is overriding, because this is important also if you're planning TEER. As you know, the higher, the more difficult, even for experience. So in this case, it's not very high, even less than 3 millimeters. The leaflets are a little bit thickened, but I would think that this is more fibroelastic deficiency more than myxomatous disease and not very thickened leaflets. So what is your plan?
So let's move on. I will show, for a matter of time, I didn't put all the grasping attempt that I've done. This was a little bit tricky to treat respect to the previous one that was very easy. So I used at the end, I used the dependent leaflet capture, as you can see in the left panel. And I implant the first PASCAL ACE in a central A2P2. But you still can see this eccentric residual jet. This was the first attempt that I've made. Then I decided to reopen and reposition more medial when I understood that I have to use another PASCAL ACE implant. But the result, I didn't show the result, was even worse on this. So I went back to my previous implant and I start A2P2 central with these results. So this is the result after the first PASCAL ACE implant. I catch the prolapse, but we still have a medial residual severe jet, I would say, it's still at least moderate. As you may know, it is better to go when you implant two devices to go first medial and then move lateral because it's easier to do. But in this case, I do the opposite because this was the best result with the first implant. And then, as you can see, I went with the second PASCAL ACE implant in the medial position. It was very easy to go down. The angiography is a good reference point to go with the second device. device, and it was easy to go in the medial part, even if the hole was not so big. And this was the result of the second implantation. And as you can see, even from the 3D image, we have no more, I will say, trace mitral regurgitation. And that's all.
Fantastic. Again, another great result. I think there's an important learning here. I mean, the first one you've done with the P10, and the second morphology you have approached with the PASCAL ACE. Maybe Stefan, can you quickly explain why would one use rather PASCAL ACE than a P10 in a prolapse?
Well, in prolapse, the foreshortening of the leaflets with the PASCAL ACE is more pronounced. The device has a 1 millimeter longer arm, and the central spacer is flat. It's not as big as we've seen in the functional disease. So the effect is that you have a larger annuloplasty effect. Also, the device has 6 millimeter width instead of 10 millimeter width. So in the commissure area, like here in the medial part, it's far easier to separate out between the cords and to get a perfect result without rolling the leaflet. I think that's the central part here.
Would you have used the PASCAL ACE as well, Jörg?
I think so too. Yes. One aspect which I think is important, if you do such a strategy that you go in the middle first and then place another one more medial, is that you need to be careful that you have a high enough puncture of the septum, so that you really can bend down safely into this medial aspect. But this looks perfect, and I would probably have done the same strategy going into the center first and then place the second one.
So that's also important. The approach to the valve matters, the trajectory, how you do your transeptal puncture. When this all is done properly, then you have a much faster and more effective procedure. In degenerative and in prolapse, sometimes we end up with good MR reduction, but there's still a lot of mobility, and then there's a discussion whether it requires another device for the longevity. Would you want to comment on that, Harald, please?
I think we have seen the data that we have no partial detachment in the long term with all these devices, and I think when I would have had a perfect result like this, I would keep the mobility as it is and not put in another device here.
Absolutely.
Yeah, I think it was pretty straight.
Then we switch gears a little bit and move away from the mitral valve. Thank you very much, and we go.
Thank you, yes. Perfect.
We will go over from the left to the right to the tricuspid valve. We are in a very comfortable situation that we can witness an incredibly active field of tricuspid transcatheter interventions. We see new innovations, we see new devices, new therapies. We also are in a quite comfortable situation when it comes to how the body of evidence is created. There are multiple studies in the field, and there's still a lot for us to learn, but at least our knowledge is increasing day by day, more or less. And again, here we will start with a summary of the latest evidence. Please.
Yes, thank you. And for a clinician like me, it's a great question you asked me, because you said what's new in the tricuspid TEER, and which I think, or why I think this is a great question, because nobody in the audience would expect a comprehensive answer to this. So I probably will try to give an answer, and I've selected 2 studies that to prepare some kind of an answer. The first is a TRILUMINATE study. The TRILUMINATE study was, as you all know, randomized controlled trial comparing TEER treatment with a clip device compared to medical treatment. And as you can see, the TEER treatment dramatically reduced the grade of severe TR. And this leads to clinical results. You would nicely see that if you were able, if the study group was able to reduce the TR to moderate or less, the patients had a major increase in quality of life. And if it was not possible to reduce TR, then patients were still symptomatic. And this reduction in TR seems to be some kind of a dose effect. The more you reduce the grade of the TR, the better the clinical effect was. So these were all randomized data. Can we translate these important results in a daily practice, everyday patients? So I want to present the TriClass, 1-year data from the TriClass study. That was a prospective multi-center single-arm post-market clinical follow-up study. And the purpose of this study was to study the safety and effectiveness of the PASCAL system. 300 patients have been included in this study, and they all have had to have a severity of tricuspid regurgitation of more than severe. So there are 3 results from this study. First of all, the TEER treatment is safe. You can see here very low major adverse event rates in the early phase, but also up to 1 year. And you can also see a very low mortality, which I think is very impressive. You have to remember that more than 75% of the patients have been in NYHA class 3 or 4 when they entered the study. Second, these results run in clinical effect. There was a great reduction in heart failure hospitalization, especially compared to the year pre-procedure, but this may be multifactorial, not only a result of the TEER treatment, but the data are quite impressive. We can also show that with the PASCAL system in this everyday patients, it was possible to reduce the grade of TR 90.7% of the patients to moderate or less in this patient group. And this also results in a significant improvement in NYHA class, quality of life, and the 6-minute walk test. Now I can try to summarize these data and probably try to give you an answer. TEER treatment for tricuspid regurgitation is safe. It's a safe procedure. It is morphologically and functionally effective, as you have seen in echo data. It's clinically effective, measured with NYHA class, quality of life, 6-minute walk test, and rehospitalization. It seems to have a dose response. The lower the TR is after the procedure, the better is the quality of life. It has durable results, at least for 1 year, and it may be a class effect across all the available technologies we have. So I think with TEER treatment of tricuspid disease, we have a well-established treatment, and we are now going into the next phase. We are leaving the period where we have only highlights sessions about TEER treatment. We are now deep in clinical medicine, and we are opening up a lot of new questions, like what is the right patient selection, discussing right heart disease, and so on. Thank you very much.
We move on with your part, and then we have a discussion of the 2 parts.
Yes, thank you very much. It's a pleasure to be here and to talk a little bit also from my side what's new in tricuspid TEER. And I was asked to show a little bit what we have done in terms of the PACE registry. PACE stands for the PASCAL for tricuspid regurgitation, a European registry. And this is an investigator-initiated registry and it's still ongoing. And the goal is that we're going to collect the data of almost 1,000 patients or more than 1,000 patients. And as you can see on the next slide, we already have more than 800, not 700 patients as depicted here, collected. And all those patients will be central analyzed, these echocardiograms, so that we have comparable to such a trial, also some core lab analysis. And you see many of those sites are depicted here, are contributing very actively to this PACE registry. You have heard that we had a first generation and then the second generation with the PASCAL Precision system. And as depicted here, we were trying to get more than 500 patients for each group. And there are some slight differences, also comparing those patients to the TRILUMINATE trial, which was just mentioned. The patients are old, almost 80 years. We have a high prevalence of cardiorenal syndrome with around 75 to 80%, elevated liver enzymes for cardiomyopathic syndrome, and New York Heart Class 3 and 4, as we are very similar to the TriCLASP trial, is almost 90%. What you do see on the right side is a high technical success rate in clinical practice, 99%, with about 1.8 devices which are placed in the tricuspid space. You see that the PASCAL A system is more increasingly used for the tricuspid valve, almost 99% in the latest series, and the independent grasping, a feature which is really very nicely to be used with the PASCAL system, is being used in 97%. As I said, the trial or the analysis is ongoing. These are echocardiographic data for the more than first 500 patients. At 1 year follow-up, 352 days after the procedure, and you see very comparable to what you have seen before. 81% have a durable reduction of the tricuspid regurgitation to moderate or less TR. And this translates into this clinical improvement shown here with the New York Heart Class. 2/3 of patients very consistently are in New York Heart Class 1 or 2. We did a little bit more detailed analysis looking at the different device positions. You see that about 2/3 of patients, the device is being placed in the anteroseptal line of coaptation. About 40% get a one-device strategy, 50% have a two-device strategy, again, mostly with the placement of the device primarily in the anteroseptal line of coaptation, and less than 10% have 3 or even more devices. We were also looking about the coaptation gap, and we're measuring this in the core lab, and you see that the mean coaptation gap, which is the maximum gap where we are placing the device, was measured around 6.3 millimeters on average. And more than 28%, so almost a third of patients, had a gap size of 8 millimeters or more. And as you can see on the right side, this translates also or is associated with the procedural success rate. When the gaps are small, below 8 millimeters, we can achieve MR2 plus or less in almost 87%. And this drops a little bit if the gap size is increasing, but still it's in the range of 70%. Very similar to what you have seen by Carmelo on the mitral side, we have also some internal Edwards data collected by the clinical specialists. And comparing here two timelines, again, the first generation on the top and the PASCAL Precision on the lower side of the slide. What you do see is that functional TR is getting less prevalent, it's reducing from 82 to 78%, so indicating that we're treating also more complex disease with degenerative TR or mixed disease, also on the tricuspid side. What I think is very intriguing to see that there is an improvement in TR reduction. I mean, you're looking at the TR1 plus rate or less, which increased from 53 to 59%. This might be twofold cause, of course, a learning experience over time, but it might also reflect the better durability with and precision, which we can achieve with a precision system. Procedural data, success rate very high in clinical practice, but also is very nice to see is that the procedural safety in terms of the SLDA rate is coming down. It's already very low with 2.7% in the first series of 1,700 patients, but also in the second series now it's even below 2%. And also the time for the procedure has come down significantly. Thank you very much.
So very, very interesting data. Let's get started with the age of the patients. So that's astonishing that we start to treat tricuspid disease in 80-year-old patients. How does that come along?
On average.
So on average, exactly. So are we? I think we are treating the right patients. You show that they are significantly improved, but is a TR a disease of a very old patient, or are we just missing the younger ones?
No, I think it's mainly a disease of the elderly population. Of course, we're going to see patients also in the 70s, but rarely we do see patients who are really in the 50 or 60 years of range. It is a functional disease, very different than what we have seen in the Class 2D trial on the mitral side, where we have degenerative disease, where we're treating younger patients, perhaps. Although there was also the age range was also high. But the functional TR is really a disease of the elderly, yes.
Okay. And did you observe a change in device strategy over the time? You didn't show us that. So do we place the PASCALs at different positions now? Do we have more to device procedures than when you started the registry? Did you see there a change, or are we there?
The number of devices is still around 1.8, so the number did not increase. The position, we didn't look in detail yet. As I said, the registry is still ongoing, but it's, I think, very important to see that the results are coming down, improving, meaning that the TR rate is improving over time.
Martha, it seems the lower the better, that's obvious, or at least it seems to be obvious, but what should we be aiming for? Is moderate or less, is this okay as a treatment goal?
I think we should aim at 0, but we have the concern, particularly in very advanced right ventricular dysfunction, if we should be so strict or not. I guess that we are, with 1+, we are happy, but we always like to have perfect results.
I mean, we have different choices now, right? There is TEER, there's also a replacement, so obviously it matters what we would predict in terms where we end up. Carmelo, if you would predict that the chances of getting it down to moderate or less are high, but probably not mild, is this good enough to go for TEER?
Well, from the data that we have, it seems to be good enough. So I think that we are in the right direction, but probably it is what happens with the mitral. We should select best our patient. So we have not to wait too much, because the most important thing is the right ventricle, as we know. So maybe we have to start to treat this patient earlier.
When you treat patients with TR, what do you want to achieve? That they live longer, that they live better, ideally both? And what is still sufficient as a clinical sort of target and treatment goal?
Yeah, my first goal would be that they'll really live better. And if you look, we have a very old population in our patient group, and I fully agree, because the patients we are treating now, they are coming too late to us. And it's still not out in the field that we can treat tricuspid disease. And I think this is one of the reasons why the patients come so late, come so old, and then with such severe disease, also severe right ventricular disease. And currently, we really do not know if the patients will be doing really better when we treat them very early. We have to see. In the surgical field, you know that in all the studies, patients were around for for singular tricuspid surgery, patients are around 50 to 60 years old, and they still have a really high mortality, even in these younger patients. So currently, I don't have the perfect answer to your question, but quality of life would be for the patients we treat now would be, for me, the major goal.
Stefan?
I think we're still in a transition. So we have a 2B indication that is less than 3 years old. We have no indication in the US. I think we have a 1-year mortality that is below the intra-hospital mortality of surgeons with 2-decade younger patients. So I think we should be happy already. But of course, this is a transition where we will get better and better. And the addition of replacement will bring down TR to mild or none in a vast majority of more than 95 of the patients. But we're not certain yet if the patients between 80 and 90 years of age really take a benefit from this. And this will be further elaboration in registries and randomized trials, in my opinion.
Good. Now let's talk a little bit about the procedure. Let's stay there, please. What are the features you use of that device when treating TR? What is it that you need to do a safe and effective TEER procedure on a tricuspid valve?
Well, I think that there are a couple of aspects. One, we already have seen also in the data that this independent grasping is one feature which is very intensively used, so you can really get a lot of leaflet in the first clasp and then move over to the other side and do this again. You can focus your imaging on this clasp, so this is also an aspect which allows us to get a very safe assessment of the leaflet capture, which translates into these very low SLDA rates from my perspective. And if you do this independent grasping, you can also maximize the annuloplasty effect, which we're going to see because we have a lot of leaflet in the device. A second important aspect is that with the elongation of the device, the handling of the device in the right ventricle is going to be very safe, so that we can also back up, get out of the tricuspid valve if we have some entanglement with one of the cords, which can sometimes happen. So it's also a very safe procedure. And we have seen this in also other trials that the tricuspid field, that we can treat those patients very effectively and safely.
What's a complex valve then for you, Jörg? And on the tricuspid side, it's not well defined yet, since most of them are functional, but where would you say stay away from it, or where do you have to have specific strategies? Well,
I already showed this analysis of the gap size. I think increasing gap size is something which we need to look at in the future. Where is then the gap size where perhaps a replacement therapy might be a better option? And we can then we of course need to see where's the main shed. If it's anteroseptal, then it's usually an easier patient to treat. But if it's more posteroseptal or into the anterior posterior commissure, then it's getting more complicated. And finally, the number of leaflets or scallops is something which makes the treatment much more complex. The more scallops we do have, the more complex it gets.
It gets more complex, but it doesn't mean that it cannot be done.
Of
Agreed?
course.
Okay. Thank you very much. We stay within the discussion about the procedure, how it can be done, where to put the devices. We will now ask Tiffany Patterson to present one of her recorded cases and continue the discussion. And in between, we will also have Marta once again to actually explain to us what we see. Please, Tiffany.
Thank you. So thank you very much for allowing me to present a recorded case. My name is Tiffany Patterson, and this case is recorded at St Thomas's Hospital. I'll start by giving you a background of the case. So this was a tricuspid transcatheter edge-to-edge repair with the PASCAL Precision. So this was an 85-year-old lady. She had a BMI of 21. She was very independent and active, but I noticed that she'd been experiencing progressive dyspnea, worsening peripheral edema, and general lethargy. She had long-standing atrial fibrillation and had a previous stroke in 2010, background of osteopenia, diverticulitis, and was on medications including digoxin, edoxaban, furosemide, just 20, atorvastatin 20. Blood showed an elevated NT-proBNP at 1,758. So this is the transgastric view, and Marta will go into more detail in a minute, but just to orientate you, we've got the septal leaflet towards the right-hand side, the posterior leaflet at the top of the screen, and the anterior leaflet. And then what we see is a very central jet of what we felt was severe tricuspid regurgitation. And this is our working view, so our mid-esophageal RV outflow view, and it confirms to us that this was a very central jet of severe TR, felt to be functional with dilatation. So in summary, the echo findings demonstrated severe TR. We had preserved LV and RV systolic function and significant biatrial dilatation, which we felt was the mechanism of the tricuspid regurgitation. We discussed our heart team. She was elderly. It was a low-risk procedure. We felt it was reasonable to proceed to TEER here, given that she was significantly symptomatic. And I'll hand over to Marta for the imaging analysis.
Thank you, Tiffany. So we move to the tricuspid side, and I'm showing here a modified four-chamber view. So we have the right atrium here, the right ventricle, and you can see here that you have very enlarged atria shown before in the movies. So this looks like atrial secondary tricuspid regurgitation. And we see here also very central jet with very long what seems the septal leaflet. We are not sure in this view, but seems close to the septum, so it should be the septal view. So this is, as Tiffany mentioned, this will be the working plane during the procedures. If there are here, so we will see what we call the right ventricular inflow-outflow, because we see the outflow and the inflow. We have the aortic valve in the middle. So when we do the biplane or the orthogonal view across it in the middle, we have the corresponding orthogonal view where we see the septal leaflet here and another leaflet here, which is a nice view, not to see which leaflet is it, because we will see that in the transgastric, but it's nice to see the length of the leaflets that are appropriate and the location into the septal and lateral aspect. So it's again a very central jet as we anticipated in the other view. And let's move to the transgastric view. This is a difficult image because it's a still image, but we can imagine here septal, posterior and anterior. So how do we know this? Because probably here, which is more dense, more white in the echo, corresponds to the papillary muscle. If we were doing live echo here, what we could do, we would go there with a biplane view, with a 3D probe. We would cut here where we see this thing more white, and we would confirm that this is the anterior papillary muscle. So we would be sure that we are there. The other aspect that I want to highlight to Tiffany or to the interventionalist is that in the septal leaflet, which is this one that you see here, you have here something that may seem an indentation, okay? So you also have to be aware of that. And finally, looking at the anatomy and the color flow, it's important in this still image that you see that this is a very central jet again. So it seems in the line between the septum and the anterior leaflet. And again, it's difficult in a still image, but we can imagine here where is the regurgitant orifice, as we did before for the mitral, and I think the gap size was 4 millimeters. So that could be, the summary could be atrial secondary tricuspid regurgitation due to annular dilatation with long leaflets, 3 leaflet tricuspid valve, no restriction in the motion of the leaflets, particularly in the septal leaflet, as they co-opt very horizontally, we saw in the still images and in the movies, with a central gap of 4 millimeters.
Perfect. Thank you very much. One question in between. Jörg, you were just asked, what is a complex valve in the greater scheme of things? Is this where would you put that?
I think the gap size tends a little bit more to a not too complex valve. I was not so sure about if it's only 3 leaflets. I thought when I saw this, at least on my monitors, that there might be perhaps even 4 or also 4 scallops, so 2 on the posterior part, so which might be a little bit more complicated, but it should be easy to treat with the PASCAL system.
So good case for TEER.
Very confident.
Okay, good. Well, then let's see.
So we felt similarly. We felt it was a central gap, and we felt it'd be a suitable case to proceed with. So just for those who don't know, I'll start by just describing the components. I'm just pointing to the guide catheter with my left hand and the flush ports at 12 o'clock for the tricuspid. And in the middle, we've got the steerable catheter handle and then the implant catheter handle on the right-hand side. So I'm just checking everything is aligned where I want it to be. So now you can see the bicaval view on the right-hand side of the screen and the fluoro image in the top left. And what I'm doing with a steerable catheter, I'm rotating downwards and gently advancing just to bring the device out. The implant catheter itself is back, but the steerable catheter, I'm advancing slowly and just turning down onto the valve. And that's until I get to the working view, as we mentioned, was the RV inflow, outflow. And I'm approaching the valve here and just trying to come into view, see where the largest jet is. So I'm just doing what's called a trajectory check there, for those who don't know. And that's just where I'm advancing the device backwards and forwards, just onto the valve, just to see which direction it's pointing at and if I'm happy with that direction. And you can see that I'm turning the handle on the implant catheter, and that's opened the device. And that will enable me to do the clasp check. You see, I'm releasing the clasps there. So there's 2 clasps that facilitates independent grasping. I've released them just to check, and I've confirmed that the darker grey clasp is the septal leaflet. I had a bit of septal hugging now. We can potentially discuss that later, but I just adjusted for that slightly, just to fix my trajectory onto the valve. So I felt comfortable there, I was happy, so I was ready to cross the valve. So I've closed the device. And I'm going to try and cross the valve here. You might be able to see that there's quite a big papillary muscle cord just below the valve. And I may have gone a little bit too deep. I was trying not to dive too deep before I opened it, because as the device opens, it also pushes forward. And I guess the concern here is getting trapped on this cord. So I've gone below the valve, I've reopened, and I'm going to check orientation here in the transgastric view. We did check it before, but it just wasn't shown in this section of the video. But we're just checking orientation here. This is a slightly 2-8 orientation. I think what I ended up doing was slightly more 3 and 9, just to get that central jet and to get those leaflets in. But I'm just rotating it. So just to orientate you again, we're looking in our working view, and this is on the right-hand side, it's the RV inflow, outflow. The device is open and below the valve. And I'm attempting to see if I can get the device, the leaflets to sit on the device. And what I'm trying to do, but what I end up actually doing is I seem to come up, trying to get this lateral being the opposite of septal, probably the anterior leaflet. I'm trying to grab this leaflet, but I end up coming up. And then when I go down, I seem to hit the cord as I'm going down, and I get bounced around a little bit. And what my echocardiographer, Corinne's just trying to do is trying to optimize this image so that we can get the device paddle into view, but also the leaflet at the same time. So while we're trying to do that, we're going backwards and forwards a little bit of bouncing. And this brings us to a good moment, actually, to discuss how to optimize the views here, because we were clearly struggling with visualizing this lateral leaflet better.
So
over to Marta,
may I
yes,
make
please.
some suggestions on how to optimize? So
Tell us what to do.
sometimes it's difficult and we struggle to better visualize the leaflets, because if we don't see the leaflets, we are all lost. So how to improve, we know the challenges of visualizing the tricuspid valve. I could make some suggestions, particularly putting a roll under the right shoulder. This comes a little bit on the lateral decubitus and brings the right heart a little bit closer to the probe. And of course, other tips and tricks, like aspirating air from the esophagus. This is something that we learn very much from the anesthesiologists in the OR. And also, finally, important, the lateral wheel flexion. We don't, all the TE probes have two wheels, okay? One which is the big one, usually, that does the anterior-posterior flexion, antero and retroflexion, and the small one that does the left and right flexion. So if we look at these images from the CT and we see that the esophagus is here, we are here with the probe. So our angle of insonation is usually not that good and much better, of course, for the mitral. So if we do a little bit of lateral flexion and we go a little bit right from the stomach, we will better increase the visualization. These are not magic tricks, but it may help, particularly the one on the tilting.
That's a beautiful demonstration. This is so important. And sometimes if you think that you can't get proper images, if you try and turn and twist and move in and out a little bit and be patient, that very often you will still end up with good results. And this is really of utmost importance. And I think a very important demonstration of how to improve the imaging. Thank you. Okay, let's continue.
Thank you, Marta. So we used a couple of techniques, not all the ones that Marta suggested, they were fantastic, but we did use a few techniques just to try and optimize our imaging so that we could focus on this lateral paddle and see if we can get this leaflet onto it. And what you can see now is on the right-hand screen, the lateral leaflet, so the one furthest away from the septum. I'm pretty confident that I have it, and I'm starting to drop this clasp down onto it. And then I'm just neutralizing. And I've just come back again, and I'm trying and get a bit more leaflet, I think, from what's happening here.
That seems to be.
And I'm going under. And just trying really just to come under the leaflet and try and get as much leaflet as possible and drop the clasp down. Bit of a small rhythm issue there. And then I've swung septal, so I've clocked the device, so that's gone towards a septal direction, ready to try and get this septal. So I've done independent grasping here, which is what was mentioned earlier. And just to also tell you that I'm using the PASCAL ACE device because it's very low profile, it's easy to maneuver beneath the valve. So I feel like I've caught the septal leaflet there, and I've dropped the clasp down. And neutralizing again there. And I think then I just wanted to just check the orientation. So I think we went into the transgastric view. So you can see it's probably somewhere between, on a clock face, somewhere between 2 and 8 and 3 and 9. And we tend to close in the transgastric view. I'd be interested to know what other people do, just to see if these leaflets are coming in nicely into the device. And then with a little bit of colour just over that device, we're looking to see if there's any residual TEER. You may have noticed actually the TEER at the beginning of the case was slightly less than the pre-procedural workup, and that's because we tend to diurese these patients quite aggressively with an inpatient admission. So we tend to admit them a few days beforehand, try and reduce the coaptation gap, try and offload them and optimise them as much as possible before during the procedure, mostly just to make sure we get the best outcome for the patient. And we're going through a series of checks now. We had a look in the transgastric view, and I'm just opening up again. And we just like to have a look to see the pulling in of the leaflets. Also like to see if the leaflets are going all the way into the center of the device. I think we had a question about the lateral leaflet because it's quite mobile. Wanted to just make sure that we had enough of that. And then we're just closing again. I think it's very reasonable to take your time, do as many checks as possible, and ensure that you're happy with your result. So after we've closed this in the mid-esophageal RV inflow-outflow view, we have a look in with colour. And then we've gone back to the transgastric just to do another check to make sure the leaflets are inserted fully. And I think the issue here was, I'm not sure if you can just see, but to the left-hand side of the device on the right-hand view, we have this prominent cord. And I think what we were worried about was that we maybe didn't have the whole leaflet, but what we were seeing was the cord bouncing forward. We thought maybe we hadn't caught the leaflet properly. But then once we looked at it again a few times, we realized actually we did have the leaflet. It was just the cord bouncing in and out. So as we're opening and closing, we're just reassessing that. So although it wasn't a particularly challenging case here because the TEER was optimized and reduced quite significantly, we did want to get quite a good result here. So we were trying to be quite perfectionist about it and trying to reduce the TEER as much as possible. So I think I'm comfortable there that that's residual mild TEER. And I think our echocardiographer is happy as well that we're probably not going to need a second device. That's the next thing we were considering, whether or not we'd need an additional device in addition to this one. And then you can see the colour in the RV inflow, outflow. And we're just doing a sweep through to see if there's any other small jets. And I think we're relatively happy that there's no residual TEER, and nowhere else we would particularly put a device. And then we checked the gradient, which was 0, 1. Again, happy with that. And so we've agreed, all of our checks were done, happy, we're going to release the device. And this is just the implant catheter where I've removed the implant catheter, the back of the implant catheter handle to really reveal the sutures. So I'm just undoing the sutures there. These are now independent of each other. And I'm releasing the septal suture first. That corresponded to the dark grey lever. And then the lateral or anterior one. And these pull out very smoothly, very nicely. And we tend to do this under fluoroimaging and also under echocardiographic guidance so that we can see things clearly, see if there's any loss of stability, see if any leaflets come out. So I'm happy things are stable. And so I'm now going to release the device, and I'm turning the actuation knob just so that the wire can detach from the device itself. So as I'm anti-clockwise turning, I'm retracting, which will then release the device. And again, just constantly checking fluoro, checking the echo, making sure everything's stable. And then once that's released, you pull the implant catheter back into the steerable and then everything back. And then we do our post-release checks. So just checking here to see if there's any residual TR. There's a little mild TR jet that actually resolved on the post-procedure transthoracic. There's only trace TR. And I think we were pretty happy with that result for this patient. And I think that's important. Once you release the device, just making sure the gradient's the same and making sure the regurg is the same. Okay, thank you.
Thank you very much. Did the patient improve symptomatically?
Very much so. Dramatic, which we see a lot.
I mean, we had a discussion about the complexity of the valve, and we agreed that it was in terms of complexity within normal range. But I guess these are the patients we want to treat, where we end up with a perfect result. Sometimes we can do crazy stuff, and we get good results also in very complex anatomies. But ideally, we want to be able to predict the outcome and end up with good outcome, and this is what exactly we've seen here. You've demonstrated that a couple of times you opened and closed the device, because that was, if I understood correctly, helpful to appreciate how much leaflet is in and out. Is that something you do often, and would you see any harm by doing that?
In terms of maybe the leaflets falling out, or harm, you mean?
Yeah, but in general, I mean, you have both leaflets in, and then you open and close again. Just share with us your experience, whether that's something you do quite often.
We do. We like to look at it. Sometimes if we haven't recorded the closure, we like to just reinforce. Also in the transgastric view, it's quite nice for us to see the leaflet insertion as we open and then close, and we see the valve coming together. We also see if the device is swinging or not, swinging one way or the other. That might suggest that we haven't got enough leaflets. So we do that, but I'm open to discussion about what your thoughts are on that.
Any other thoughts? But I have to say I do it also in between, because there's some things you can only appreciate while the device is closing. And if you're in doubt, that as always, it's good to have more information. And the risk of opening and closing, from my perspective, is really low, and you wouldn't lose the leaflets as long as the clasps are still down. We've seen the assessment of the gradient. Here it was 0, easy decision. Where's the magic number here?
To be honest, I've never seen significant gradients after fixing a tricuspid valve. So I'm pretty confident that despite the number of devices we put in, we tend to still have very, very low gradients. I don't know if any of the other panel members have experienced that.
Any other comments about the gradient?
We looked at that in the past in a series of patients which we treated in Munich, and up to a gradient of 3, we didn't see any impact on the 1-year survival or the rate of improvement. Even if you look at higher grades of 4 or 5 millimeters of mercury, it didn't change. Higher grades than that is almost unrealistic to obtain, because the valve is so large, or you really need to zip down the entire valve. Of course, you can, with 10 devices, you will always close the valve, but that's unrealistic. So it's really up to 5 millimeters of mercury. It appears to be safe, but we try to stay with 3 millimeters or less.
So, Tiffany, you mentioned that you aggressively pre-treat the patients. I think about this very important issue on one side, but it doesn't leave that with you some uncertainty regarding what will happen after the patient goes back to normal fluid status and TR is coming back. Is that an issue we should consider? To say how much of annular reduction are we doing with forced diuresis, and we all know that we can't maintain it over time in the patients. But how do you deal with that? Is 10 liters too much, and 5 is exactly what you're aiming for, or is it a distance you monitor on the imaging, similar as you have to do it for Evoke to see what's the dynamic of the annular size?
So we're not particularly fixed about how much we're offloading them. We just tend to bring them in a couple of days beforehand if they seem quite substantially overloaded, try and offload where we can and optimize them. But you're right, and certainly we're still learning about what happens to these patients after they come back. The vast majority, we haven't seen a problem on follow-up TTE, but we have had the occasional case where actually their diary's so well beforehand, we put a device in, the device is still working very well, but they've got severe TR. So maybe there is something to learn from that.
And regarding the chords, Ralph, do you have specific tips and tricks, if you deal with this prominent chords or even the papillary muscles? Because I think we all see the trouble quite often on the right heart side.
Yeah, I think what we've seen is that you have to take your time when turning the device, especially in the ventricle. So it's a very calm procedure, and I would avoid turning or grasping directly into the papillary muscle area or into the central cords because the forces are highly elevated there. What we've seen with the opening and closing means the clasps are very durable with the leaflet insertion, so you can really do this. And you would also look a little bit perhaps for a displacement of the central cords. So if you see this while opening and closing, you may have a misrotation. So I typically also use a little bit more fluoro to control perhaps the rotation, that you don't see the bouncing and you don't see a displacement of the cords while opening and closing. And then you're in a parallel position to the cords, and this is always beneficial. And I think what we've also nicely seen in the live case is to use multiple imaging views. So not only to stay in the mid-esophageal, but also to move down a little bit to go to the transgastric, where you see these cords nicely in their orientation, and to use these additional views, I think.
Maybe a quick discussion about where to put the devices. I think here it was more straightforward. Sometimes you have MTR all over the place. Carmelo, where would you start? And are you more in favor of putting all the devices anteroceptally, or would you always put them where you have TR?
What we have learned is that anteroceptal commissure is the most effective on reducing the tricuspid regurgitation. So this is, I would say, the first side of implant, and it is where it is located the majority of the jet. We know that the anteroposterior is not affected almost at all, and the second chance is to posteroceptal. And when you plan to do a procedure like this, it is better to go first anteroceptal and then posteroceptal, just to avoid the shadowing of the clip into the posteroceptal position. So this is my strategy usually.
Jörg, you used to be quite a supporter of the Clover technique, so placing devices anteroceptally and posteroceptally. Have you changed your approach slightly, or?
No, it really depends on the individual pathology. If the anterior leaflet is very long, then also two parallel devices into the anteroceptal line of coaptation, it works very nicely. When you have a patient where the anterior leaflet is rather short, then we tend to still do a lot of these Clover techniques, or sometimes even place two in the posterior septal line of coaptations, and if the anterior is very, very short, that works also very, very nicely. So it really depends on the individual pathology. There's no one cooking recipe which fits for all.
Unfortunately, never. Okay.
So I think we had a terrific session, and to wrap it up, thanks to all you guys. We saw 3 terrific cases, and the applause is, I think, already to you, or maybe it's coming from somewhere else.
Yes, it's not us.
I didn't get that, so I'm getting confused. So what did we learn? 20 years of TEER. We saw the data on degenerative disease. It's very impressive to me. It's very motivating. And we see that we figured out tricuspid and we can treat it. And with PASCAL Precision, I think we have really 2 tools, 2 implants, and a lot of safety issues, but also technical things that are used in practice. And I'm looking forward to next year, where we will learn about edge-to-edge repair with the PASCAL Precision in addition to what we saw today. Thanks to all of you, and have a nice evening.